Hey, Dr. O here, and welcome to the digestive system. There's a lot of moving parts in this system, and we're going to look at them all. So let's get started. When Mother Nature puts together a tube in the body, there's always going to be at least 3 layers. And in the intestinal tract, we're going to find a fourth one. But what are the 3 that we're going to find everywhere, no matter where we are, whether we're in a blood vessel or a ureter of the kidney or the urethra or the intestinal tract? You're always going to have an inner lining, which is known as a mucosa. You always have that. You'll always have some sort of a muscle layer, and then you're going to have some sort of an outer covering. And in the case of the intestinal tract, we're going to call that a serosa. So in the intestinal tract, also known as the alimentary canal, we are going to have all 3 of those, but we're also going to have this additional layer right here known as the submucosa. So let's take a look at each one of these layers and see what they're made of and what's in there. Now the inner lining, the layer that is closest to the lumen of the intestinal tract, is known as the mucosa or the mucosal layer. And this is going to be a lining that's made up of epithelial tissue, no surprise there. And beneath that epithelial tissue, there's going to be a basement membrane known as a lamina propria. And then in the mucosal layer, we're going to see a little bit of smooth muscle that is going to allow the mucosa to scrunch up. Now, this muscle layer is not going to help move food through the intestinal tract. This is just specific to the mucosal layer and allows the mucosal layer to kind of scrunch up and move around a little bit. So what is the mucosa doing for us? Well, it's going to harbor cells that can secrete mucus, hence the name, and digestive enzymes as well as hormones. Now, believe it or not, the intestines, the intestinal tract, has a neural network and a hormonal network that is really, really dense. And in fact, we often call our enteric nervous system our second brain because it's so elaborate. And as we get into learning about different things that are happening as our food moves through the digestive tract, you're going to see that it's really important for the intestines and the stomach to all be communicating with each other, and we're going to be doing that through hormones and neurological input. And then the gut also has to be able to communicate with the rest of the body. So it's an extensive network, and so there are a number of hormones that get released from the intestinal tract, and that's largely going to happen because of the cells that are in the mucosa. The other thing that the mucosa is going to be responsible for is doing absorption. So as we digest our food, we have to have a way to move it out of the lumen of the intestinal tract, that open area, and get it into the blood supply. So absorption happens here as well. And whenever you expose the inside of the body to the outside world, and technically what's in the lumen of the intestines is in the outside world. I know we tend to think of it as, inside there, but it's really a continuation of our outer membrane. Then with that, keeping that in mind, that whenever we do that, we need to have an immunological presence. So just like we have substances on our skin that can provide defenses against things that will land on the skin and try to gain entry into the body, we also have things inside of our mucosal lining that are there to prevent entry of pathogens into our body. So we're going to have an immune presence there as well. So the mucosa is doing a whole lot of stuff for us. So what sort of epithelial tissue are we going to have as our lining? Well, largely it's going to be simple columnar epithelial cells with some mucus-secreting cells also woven in there. Now that's going to be true throughout the majority of the digestive tract except for the mouth and the esophagus, and then at the very end in the anus. Now, there we're going to see something quite different. There we're going to have stratified squamous epithelial tissues. Now, why would we have stratified squamous epithelial tissues anywhere? Well, I can tell you where we do have them, and we have that sort of configuration in our skin. And if we think about what our skin is all about, our skin is basically stratified like that to protect us from abrasions because the world's a rough place. You know, whenever you're walking across the floor, you're losing a ton of skin cells. You brush up against a doorway, you lose a bunch of skin cells. Pulling your shirt off, putting it on, it's abrading your skin. We don't tend to think of it that way, but that's what's happening. So instead of having a delicate layer in place, we actually have multiple layers of these squamous epithelial cells that provide some protection against abrasions that are going to happen every day. And I don't know about you, but when I eat like once a week or so, I like to go out for Mexican food, and I love chips and hot sauce. And those tostada chips, pretty abrasive. So that's why we have stratified squamous epithelial tissues in the mouth, is because a lot of the stuff that we put in there is pretty abrasive. You know, apples can be abrasive. Chemically, they can be abrasive. Cheetos, tostada chips, fried chicken. There's just a lot of things that we could put in our mouths that could abrade the lining of the mucosa if it didn't have multiple layers to it. And because all we're adding in the mouth is saliva, that food, even though it's much more moist than when we put it in there, still is fairly abrasive. And so we're going to see that stratified squamous epithelium in the mouth continue down into the esophagus, and then once it hits the stomach, we're going to see that shift into columnar epithelium, simple columnar epithelium. And it's in the stomach where we start to add a lot more fluid to our food and turn it into something that's rather pasty and maybe still a little bit abrasive into something that is much, much, much more liquidy. So we don't need to have that stratified squamous epithelium until we get to the end of things. Now, I know this is kind of jumping the gun, but I'll tell you why we have stratified squamous epithelium in the anus. By the time our food has been worked over and is being transitioned from small intestine to large intestine, it's going to have a lot of fluid in it because we've been adding digestive enzymes, which are liquid, into the food the whole time. So when our food residue hits the large intestines, it's very, very liquidy. And in large part, the large intestine acts like a sponge and starts pulling all that fluid out, so that by the time our residue makes its way to the end of the large intestine and is getting ready to be eliminated, it may be somewhat abrasive again. So that's why we have stratified squamous epithelium in the anus. So areas where you see abrasion, stratified squamous epithelial cells. All right, so we have cells that also secrete mucus. That's going to add moisture to our food, which helps ease its passage. And it also has a protective quality in that certain parts of the digestive tract, we're going to see some pretty potent enzymes be released, or other chemicals like hydrochloric acid be released. And so mucus helps protect the organs that are actually secreting these very caustic substances. So yeah, Mother Nature's looking out for us. We got to have those chemicals to do the digestion, but we also need to protect our tissues. Now, deep to the epithelium, we're going to have that basement membrane known as a lamina propria. And this is going to be made up of loose areolar connective tissue. Now, you might remember from A&P1 that loose areolar connective tissue will have collagen fibers populating it throughout, but those collagen fibers aren't going to be very densely packed. And there's going to be a lot of open space in those collagen fibers. And so it looks like loose areolar connective tissue might be sort of flimsy and gauzy in nature, but in fact it's really tough tissue. And it's tough tissue that allows for other structures to occupy those, quote, open areas where there's not a lot of collagen fiber. And so that's one of the magical and amazing things about loose areolar connective tissue. So here's our lamina propria with a lot of this collagen fiber and ground substance, and a lot of space for other things to come and populate that lamina propria. So what are we going to find in this lamina propria? Well, one thing that we're going to find is a rich supply of capillaries. Because what is happening in the lumen of our intestines is that we are digesting our food that we ate. And there's going to be points where that food is ready to be absorbed. And so we need to have a way that we can transmit those nutrients from inside the lumen across the mucosa and then drop them into the blood supply. So we embed a blood supply in the lamina propria right underneath the mucosal lining of our elementary canal. Another thing that we're going to find in the lamina propria is the immune presence. So we learned in the previous unit about MALT, that mucus-associated lymphoid tissue. And this is where we're going to see those little follicles and clusters of lymphoid tissue. Now I used the word follicle just then. And which of the lymphocytes do we associate with follicles? Hopefully you said B cells, because that's normally what we see in a follicle is a B cell. There might be some transient T's in there, but largely it's going to be those B cells that will navigate to an area, take up residence, get exposed to whatever antigens are passing by, and then start to proliferate. So B cells are the ones that move into little communities and set up household and have families. That's how we think about our B cells. So we're going to have that MALT embedded in the lamina propria. The other thing that we're going to have just underneath the lamina propria is going to be this muscle layer, smooth muscle layer, specific to the mucosa. This muscle does not move the food along in the alimentary canal. That's a different set of muscles. That's its own layer. But this little layer of muscle right here allows that epithelial mucosa to kind of scrunch up if it needs to. And I guess it needs to, because there's a muscle layer there for it. Now, underneath the mucosal layer, we're going to have the submucosa. And this is also going to be loose areolar connective tissue. We're going to have more blood supply here, additional lymphatic vessels, lymphoid follicles, submucosal nerve supply. So we're going to have more structures that are kind of there to support the functions that the alimentary canal is doing. So our neurovascular bundle will be there, as well as additional immune structures like our lymphatic vessels. We're going to have a lot of elastic tissue here, and the presence of the elastic tissue allows the intestinal tract to expand outward and then go back to its normal shape. And that's something that we need if we eat a large meal and we're trying to move a lot of food through the alimentary canal. So now we're at the muscularis externa. This is the muscle layer that's going to be responsible for creating movements of the intestinal tract that are going to move the food along. Now that's moving the food along is something that we call peristalsis. So it's these wave-like muscle contractions that will help propel the food through the tube, the digestive tube. But then we also have this other motion that the intestinal tract can do, which is known as segmentation. And what segmentation does is that it allows the intestinal tract, the muscularis externa, to keep food a little bit isolated in an area, but then allow it to mix and mash the food up in that area, so that we get a really good mixing of the food substance as well as the digestive enzymes and other secretions that are being dumped into the intestinal lumen by the mucosa and the associated glands that we're going to find there. Now, as far as this muscle layer, we're going to have two. We're going to see two all the way through the alimentary canal. And there's going to be one layer that is a circular layer that's on the inside. And when this one closes down, it's very much like acting like a sphincter. Not always, because sometimes it's just going to do a little mashy thing, but sometimes it'll kind of close off and prevent food from flowing backwards, so it acts very much like a valve. And then we're going to have an outer layer that's longitudinal, and that's going to create these wave-like motion that we see with peristalsis that allows food to be propelled through the intestinal lumen. Now, our outer layer of the alimentary canal is known as a serosa, and it's going to be made up of the visceral peritoneum. You might remember that. And it's going to be formed from loose areolar connective tissue with a single layer of squamous epithelium. around most of the organs. Now, there's going to be parts of the alimentary canal that are going to be outside of the peritoneal cavity. And when that occurs, it's no longer covered by a tissue known as a serosa. In that case, it's known as a fibrous adventitia. So you might remember it's the nature of a serosa to secrete a fluid so that the tissues are moist and there's a great deal of lubrication to accommodate the motion of the tissues that are housed within a serosal type membrane. Well, if you're outside of that sort of a cavity that has a serosal covering, then you're going to end up with a fibrous covering known as an adventitia. So who in the digestive tract is going to be outside of the peritoneum or the peritoneal cavity? Well, the esophagus, for one. It doesn't penetrate the peritoneal cavity, but it just joins up with the stomach, which is contained in the peritoneal cavity. So the esophagus is going to be covered in a fibrous adventitia. There's also parts of the large intestine that move in and out of the peritoneal cavity and are called retroperitoneal. Not that that's a big deal for this unit, but I do like to bring that in because you will learn that if you're writing a paper or doing some research. Basically the large intestine is not entirely in the peritoneal cavity. Parts of it do slip out and become retroperitoneal, at which point they will be covered with an adventitia. So while we're at it, let's talk about teeth. Teeth lie in the sockets in the maxilla and the mandible, and they're covered in this tissue called, well, it's a keratinized stratified squamous epithelium. No surprise there. We call it our gums. And dentition and the dental formula tell us basically how many teeth we have. So primary dentition consists of 20 deciduous teeth, also known as our baby teeth, sometimes even called our milk teeth. And these start coming in somewhere around the age of 6 months to 2 years. And then eventually those are going to give way to our 32 permanent teeth, which are going to be developing as we do. And what happens is that eventually the baby teeth will have their roots reabsorbed by a special osteoclast, and they'll fall out, and that will allow for the emergence of the permanent teeth, which starts happening around the age of 6 and can continue generally around the age of 12. Everything's usually done, but can take a little bit longer, upwards of maybe even 14, 15 years or so. So all of our teeth, but the third molars, which are known as the wisdom teeth, are in by the end of our adolescence. And the thing about the wisdom teeth is that they may or may not emerge. If they're going to try to do so somewhere in the late teens, early 20s. And that's usually when people figure out they're going to have trouble with them and they have to have them taken out. So yeah, if that's you, don't mess around. It's better to have them taken out young than to wait and have them taken out later. The recovery becomes more of a challenge. It's not that it becomes a riskier proposition, it's just that it's really hard to overcome it. Teeth are categorized according to their shape. So we've got incisors, which are chisel-shaped teeth, and those are the first 4 in front. You've got 2 on the left and 2 on the right. And then behind that, you've got your fangs, known as canines, also known as cuspids, because of their shape, that pointy triangular shape. And these are meant to tear and pierce food. If you can't bite it off with your incisors, then you'll move it off to the side a little bit and let your canines get in there and get a good hold, and then do a little rip and tear. And back of your canines are your premolars, also known as bicuspids, and they're called bicuspid because these will have 2 sort of fang-like shapes to them. So one tooth with 2 of these little pokey fang-like shapes to them. And we're starting to see a transition away from a chisel or fang-like structure and having a tooth that has a broader base to it. And then behind that, we're going to have our molars, which will have a broad crown and rounded cusps. So these are not designed so much for ripping and tearing like the front teeth are, but for mashing and grinding. So let's talk about what we have going on as far as the structure of teeth. So anything that is above the gum line or the gingiva is called the crown, and anything that is embedded in bone is called the root. Now, the crown is made up of or it's covered in a substance known as enamel, which is basically calcium salts and hydroxyapatite crystals, and is produced by these enamel producing cells that unfortunately degenerate once the tooth is exposed. So once the tooth comes in, those enamel generating cells die off, which means that there's no healing or recovery if we should damage the enamel later on, and that's why we have dentists, so they can take care of patching those holes for us whenever we do damage. Now, we have this portion above the gum line that's known as a crown, and then we have this portion below embedded in the bone. What's this little region right here called, this in-between space? Well, that's what we would call the neck. Teeth also have this substance called cement, which is basically calcified connective tissue that covers the root and attaches it to what's called the periodontal ligament. And the periodontal ligament is what anchors the tooth in that socket known as a gum fosses. So the union of the tooth in the socket is that joint that we previously learned was a fibrous gum fosses. Now, the gingival sulcus is a groove where the gum borders the tooth, and that's where a lot of issues can develop if you don't have good dental hygiene, because stuff gets stuck down in there and can do some work on your teeth, and that's never a good thing. And then inside the tooth, we have this substance known as dentin, which is a bone-like material underneath the enamel. And this is actually maintained by special cells known as odontoblasts. There's this open space that goes through the center of the tooth that's called the pulp cavity. And what we find in there is pulp, which is connective tissue, blood vessels, and nerves. And then we have the root canal, which is as the pulp cavity extends to the root. So that would be where we would find the bottom part of the tooth is in the root, and the nerves and the vessels that are running through that would be within the root canal. Now, the apical foramen is the proximal end of the root that is buried inside of the bone, and this is an open area, which is where the blood vessels and the nerves can enter and exit the tooth. Now, the tongue is the organ that occupies the floor of the mouth. It's composed of skeletal muscle. And the functions that the tongue does for us, well, actually does a lot, but among the things that it does for us is that it grips and can reposition and mix the food during the chewing process. This chewing process that includes mixing our food with saliva is creating something known as a bolus. And the bolus is what gets swallowed, and the tongue initiates the action of swallowing. So basically it moves the bolus to the back of the mouth, and all of that's done under voluntary contractions. So the act of chewing and moving the food around and then positioning it into the back of the mouth and the initiation of the swallowing is all done through voluntary action. Another thing that the tongue does for us is that it allows us to formulate speech so that we can make different sounds. And then it also houses our sensory organs for taste. So the tongue is doing quite a bit for us. Now, there are intrinsic muscles that help the tongue change shape. So you can flatten your tongue and you can curl it and you can make it pointy, and that's all done by the muscles of the tongue itself. But there are additional muscles that attach to the tongue and that will allow the tongue to alter its position. So the fact that you can stick your tongue out or draw it way back in the back part of your oral cavity, that's due to muscles outside of the tongue muscle itself. And those are the tongue muscles that have their attachments like within the jaw and then down into the onto the hyoid bone. Now, we have this structure that helps tether the tongue to the floor of our oral cavity, and that is known as the lingual frenulum. Also in the mouth, we're going to find salivary glands, the glands that produce the saliva. And we have a number of these, but we only want you to really know about the three major ones. One of them is the parotid gland, and this is going to be anterior to the ear and on the outside of the masseter muscle. So it's underneath the skin, but it's on top of the muscle. And the parotid gland is going to open in the oral cavity between the cheek and the gum up top near the second upper molar. Now, we have a couple that are located down low, and one of them is the submandibular salivary gland, and it's going to be medial to the body of the mandible, and the duct here opens at the base of the lingual frenulum. And additionally, down in the jaw area, we have the sublingual gland, which is anterior to the submandibular gland underneath the tongue, and it has 10 to 12 little ducts that open up into the floor of the mouth underneath the tongue. I know I don't usually lecture on the images, but I'm going to go ahead and do that here. So let's see. Here we have the parotid, and you can see it is right in front of the ear and on top of the masseter muscle. And if we follow its duct, we can see that it drains right here. So this saliva is being dropped right there. And this is actually a site of a lot of tartar buildup, and it has to do with the fact that this is where saliva gets dropped, and if there's any residual food in the body, or maybe you ate and fell asleep, that food will get dissolved there, and then it ends up forming plaque that can get lodged on your teeth in that area. If we look down below, here we have the submandibular gland, and it's located kind of off to the side, so we got a couple of those. And then underneath the tongue here, we have the sublingual gland, and we can see that it has numerous little ducts that drain it, whereas the submandibular has this one duct. So let's take a minute and talk about the liver, the gallbladder, and the pancreas. Now, all three of these glands, or organs I should say, are attached to the digestive tract. And because they are attached and not actually embedded in it in some way, they're considered accessory organs of the alimentary canal or of the small intestine. So the gallbladder, this is going to be the storage site of bile. And the liver is the organ that is responsible for making bile, and bile is important in digestion because it is a fat emulsifier. So what do we mean by that? Well, when we eat fat, fat typically comes in large globules, and our enzymes can get to it a little bit more easily and do the breakdown they need to if those big globules are broken down into small ones. So that's what we mean by emulsify. We take big fat globules and we break them down into small ones, and that's actually really important for us to be able to do digestion really well. The pancreas produces the most potent digestive enzymes that are utilized in the intestinal tract. So it supplies most of the enzymes, and it's the enzymes that the pancreas makes can digest sugars, carbohydrates, proteins, as well as fats. So it's pretty potent stuff. The other thing that the pancreas is going to produce is bicarbonate. And bicarbonate is necessary in order to neutralize the stomach acid. So when we think about it, the stomach will have dumped a bunch of hydrochloric acid into our bolus and turned it into something different, something we now call chyme. And the chyme, as it comes from the stomach into the small intestine, is coming from a very, very acidic environment into a relatively neutral environment. So we have to have some sort of an antacid present in the small intestines to offset that, and the pancreas is responsible for making that. So let's talk a little bit about the liver. So the liver is the largest organ in the body. And I said in and not of because we all know that the largest organ of the body is the skin. But once we peel away the skin and go inside, it's going to be the liver. It weighs about 3 pounds. And there are 4 primary lobes. You've got the right one, the left one, the caudate, which is the one in back, and then this weird other one that they call the quadrate, which means the fourth one. So we've got the right one, the left one, the one in back, and oh yeah, that fourth one. It lies inferior to the diaphragm, so it's just tucked right up underneath the diaphragm on the right-hand side, and it ends up being one of the most important organs in the body. And there are a number of systems that we're going to look at where the liver plays a role, and digestion is one of them. We actually talked about the liver when we were in the blood unit as well, because we said that the liver is going to take some of the byproducts of red blood cell breakdown and utilize it for other things, such as taking bilirubin and turning it into bile, and storing the iron that came from the heme groups. So the liver plays a role in a number of bodily functions, and it plays a role in digestion as well because of its production of bile. Yeah, so this is not the only time we're going to be talking about the liver because there's a lot to be said about the liver. It's up in everybody's business. Now I'm going to go into the ligaments just to give you a little bit of background. Because it's a big organ, it's going to be held in place by 5 ligaments. You have the falciform ligament, which is what's going to separate the right and the left lobes, and it attaches the liver to the diaphragm and the anterior abdominal wall. And then you have the round ligament, which is actually the remnant of the fetal umbilical vein, and it's going to form the free edge it tends to travel along the free edge of the falciform ligament. So it's another large ligament that you would see upon dissection. If we were doing dissection, you'd see that on the liver. And then we have some lesser ligaments. We have a coronary ligament and then a couple of lateral ligaments. And these are all the structures that are helping hold that big 3-pound liver in place. Now, this is something that you'll want to make note of, and that is the hepatic portal vein. Now, we've studied the portal system in one other unit so far, and that was up in the endocrine system. And we learned that there was a special little capillary blood network that existed between the hypothalamus and the anterior pituitary. And the reason for that blood vasculature, that special vasculature between those two organs, I'll call them organs, is because when the hypothalamus wants to communicate with the anterior pituitary, it's going to do so by hormones, and we just want to drop those hormones into a vascular network and then have it be shuttled immediately over to the anterior pituitary instead of having those hormones circulate throughout the body where nobody else can read them or understand them. So it's just a real short vasculature that's designed to detour the blood for a specific purpose. And in the case of the hypothalamus and the anterior pituitary, it's communication. It's shuttling the hormones meant for the anterior pituitary directly to the anterior pituitary from the hypothalamus. So here we have another portal system, and in this case it's a portal vein. So the thing that we can take away from our study of the hypophyseal portal system up in the brain is that that a portal system is a special detour that's going to move blood from one area of the body to another area for some reason other than general circulatory functions. All right, so what is the hepatic portal vein? Where's it going from? We have some idea where it's going to. So what is the deal with this? Well, the blood is going to leave the intestines and then it's going to go directly to the liver by way of the hepatic portal vein. So why is that? Well, it's because the blood is nutrient rich and it's going to give the liver an opportunity to do a number of things with it, because we've learned that, for example, the liver makes all of our plasma proteins except for the gamma globulins, which are made by plasma cells, the B cells that were activated and became plasma cells. It's also making special structures that will help with help shuttle fat around, and it can even pull some of the sugars out of the bloodstream in order to store it as glycogen. So there are all the foodstuffs in the blood coming from the intestine that the liver is going to do something with. Now, it's not going to deplete the blood of these nutrients, because these nutrients still also need to get out to the body tissues, but it will allow the liver an opportunity to take what it needs to do these supportive functions. The other thing is that the blood will be cleansed by the liver, because there's a large macrophage present in the liver that will help cleanse the blood of toxins and pathogens and maybe some other debris. Now, once the blood has made its way through the liver and had the liver work on it and do its extractions and whatever else it's going to do with it, then the blood from the hepatic portal vein will drain into the hepatic vein that will drain all the blood from the liver, and then that'll make its way back into the inferior vena cava and then back into general circulation. Now, there's a special place where the hepatic portal vein enters, and it's a region called the porta hepatis. So the word porta means door. So this is the door to the liver. So the liver door. So the liver door is where we're going to see the hepatic portal vein go through and go into the liver. And because the liver is tissue and it needs nutrients itself and it needs oxygen itself, it's also going to be receiving blood by way of the hepatic artery. So the hepatic artery and the hepatic portal vein are going to enter the liver through the liver door, the porta hepatis, liver door. So let me get you oriented with this picture. If you were to take your liver out of your body and lift it, anterior to you, this is the view that you would be seeing. So we're looking at the liver from the back side, from the posterior side. And what we can see here is that we have this very large right lobe, and there's our inferior vena cava with the hepatic veins draining the liver into the inferior vena cava. So here's our big right lobe right there, big right lobe right here. And then over here is our smaller left lobe. And then there's this lobe here in back, the caudate. The word caudate means tail, or not exactly posterior, but we could think of it as the tail. And then here's this fourth one right there, the quadrate. So the big right, smaller left, the one in the back, and then this fourth one down there. And then here we can see our gallbladder tucked in right there. Speaking of the gallbladder is a thin, muscular-walled sac found on the ventral or more anterior surface of the liver, and its job is to store bile and then to concentrate that bile over time. And it's going to contain this honeycomb-like fold system in there that will allow the gallbladder to expand and contract depending upon how full it is with bile. Now, because it is a muscular sac, that means that it's going to be stimulated at some point to contract and force the bile that it's storing out of the gallbladder and into the digestive system. And the way that it gets out of the gallbladder is by way of the cystic duct. So let's look at a picture in a second and figure out all the pathways that bile is going to flow, because there's a naming protocol and it makes sense once it's explained. So the gallbladder has a main body of the gland, which is known as the body, and there's a large rounded region, and any organ that has a large rounded region, that's called a fundus. So we're going to see one here, we're going to see one in the stomach. There's a couple of fundi that we're going to be taking a look at in AMP2 here, and this is one of them. And where it tapers down to a narrow region, it's called a neck. And then the neck will eventually become a duct known as the cystic duct. So the cystic duct is the immediate duct attached to the gallbladder, and that is going to be the way that the bile leaves the gallbladder and eventually makes its way into the small intestine. Now there's another duct called the common hepatic duct, which drains bile from the liver, and it has an attachment to the cystic duct. So there's a duct from the liver and a duct from the gallbladder, and they will merge. And when they do, we're going to call that the common bile duct. And it is the common bile duct that will have a direct attachment to the small intestine. So I think we're ready to look at a picture, so let's go ahead and do that. All right, so let me get you oriented on this image. So we're looking at the right lobe of the liver here, the big right lobe, and here's our gallbladder right there. And this is the fundus. This is that large rounded region here, and it tapers down to the neck right on this side. And then this little bit of a duct network right here, or this duct, this is the cystic duct. This is what's attached to the gallbladder. Now the liver is making bile. So it's making it in all of these lobules found throughout the liver. And so like any drainage system that we've seen in the body, we start by draining something into small vessels, which will drain into larger vessels, which will drain into larger vessels until we finally get into that largest one that's going to be the one that completely evacuates the whatever it is that's being made or cleansed or moved, shuttled around away from that area. And that's true for the liver as well. So the liver has two major drainage ducts, one from the right side called the right hepatic duct, and then one from the left called the left hepatic duct, and those will merge and form the common hepatic duct. So this is the bile coming from the liver. Now when the bile comes from the liver and we have an overflow or an excess, it actually has to make its way up the cystic duct in order to be stored in the gallbladder. But when the gallbladder contracts and we want to eliminate what's in this sac, then it's going to come back out that cystic duct. So this is like a two-way street here. The common hepatic duct is a one-way street coming from the liver. It's never going to go back into the liver. But the cystic duct can be a two-way street. But when we get ready to dump bile from the gallbladder, it's going to leave by way of the cystic duct, and then it's going to enter into the common bile duct, and this is what's attaching to the small intestine in order to get that bile into the digestive tract. Now the other possibility is that the bile that is being made in the liver makes its way through one of the hepatic ducts, either the right or the left, and then will enter into the common hepatic duct, and it'll be drained right into the common bile duct and go straight into the small intestine. That's a possibility too, which is why you can have your gallbladder removed and still be okay. It takes a little bit of getting used to because the body is used to being able to store the bile in here, but the regulation of that kind of gets altered once the storage unit goes away. And those of you who've had your gallbladder removed, you know exactly what I'm talking about. Now we've already talked a little bit about the mouth, and we know that the mouth is made up of, the lining is made up of stratified squamous epithelial cells because there's a lot of abrasion going on here. And we talked about the tongue, we've talked about the teeth, and we talked about salivary glands. So the mouth is going to be the mouth is the place where we put food in and we chew it. We mix it with the enzymes that are found in saliva, and we actually begin the process of digestion in the mouth. And as I said previously, swallowing is initiated here as well by way of the tongue. So when we think about the mouth, we're really thinking about the oral cavity. And the associated organs that we're going to find here are the tongue, the salivary glands, the teeth, all together kind of comprise, and the lips, all together comprising the mouth. Now, we can also call this the oral cavity, sometimes called the buccal cavity or the buccal cavity. And the mouth is bound by the lips anteriorly, the cheeks laterally, the palate superiorly, and the tongue inferiorly. So the mouth is bounded by those physical structures. The oral orifice is the anterior opening where the lips are, and the walls of the mouth, like I said earlier, are lined by stratified squamous epithelium. That's our mucosa. And the reason why we like those stratified squamous epithelial cells there is because they're tough, they're resistant to abrasion. Think tostado chip. And in certain parts of our mouth, we actually have keratinized epithelial cells making up the layers, just very much like our skin, in order to have that extra protection. So we're going to find that on the hard palate, on the gums, and even on parts of the tongue. All right, so the lips are called the labia, and they're comprised of a fleshy muscular known as the orbicularis oris. Now, the cheeks are largely comprised of the buccinator muscles, left and right, and the oral vestibule is going to be the recess between the gums and the lips and the cheek. So if you were to choose snuff, you would put a pinch between the cheek and gums, and you'd actually be putting it in the oral vestibule. Now, the oral cavity proper lies within the teeth and the gums, and our lips also have a couple of frenuli, I guess is how that would be the plural there. Labial frenulum attaches the upper and the lower lips to keep them in place. So food is going to pass from the mouth into the throat, and the throat is called the pharynx. And the pharynx is a large region, and it spans starting from the back of the nasal cavity, going behind the oral cavity, and then ultimately going all the way down to the point where it splits and becomes the trachea and the esophagus. Now, the region behind the mouth is known as the oropharynx, and food is going to enter into the oral cavity and then pass into the oral pharynx. And then once we swallow it, it will enter into the laryngopharynx. Now, the pharynx, at least the oro and the laryngopharynx, allow for the passage of food, fluids, as well as air, because remember, we have to share this passageway with our breathing. We're going to find stratified squamous epithelium lining this passageway along with mucus-producing glands. And we've got a couple of skeletal muscle layers here as well that are going to help move things along. Now, once we've left the pharynx, we're going to be into the esophagus, and this is a flat muscular tube that runs from the bottom part of the pharynx all the way down to the stomach, and it's often called the food tube. And because it's muscular, it has a tendency to be collapsed and closed when we're not prying it open with a bolus of food making its way through it. It joins up with the stomach at a point where it has to go through the diaphragm, and this region here is known as the esophageal hiatus. There is a sphincter where the esophagus joins the stomach, and the region where the stomach is open to the esophagus is known as the cardiac orifice, and the sphincter that joins the esophagus and the stomach are known as a number of things. Is called the gastroesophageal sphincter. It's also called the cardiac sphincter. It's called the lower esophageal sphincter. So it gets called a lot of things depending upon what it is that you're reading. The whole purpose of having a sphincter at this point is to keep the stomach contents in the stomach, because the stomach is going to be producing some potent enzymes along with hydrochloric acid to start the breakdown of our food. So we don't really want that hydrochloric acid with its pH of 2 spilling up into the esophagus, because if it does, the tissues there don't have a good way to protect themselves from that, and they can end up being damaged, and that leads to a condition known as GERD, gastric esophageal reflux disorder or disease. Now, the esophagus is going to have all 4 of the layers that we talked about. So it's going to have a mucosa, which in this case is going to be that stratified squamous epithelium. That's a continuation from what we saw in the mouth. And by the time it reaches the stomach, it's going to be that simple columnar epithelium. The esophageal glands in the submucosa are going to secrete mucus, so it's going to continue to add to the fluid content of the food as it's making its way down the esophagus. We're going to have a muscularis externa, which means that we've got muscle lining this tube, because that's basically almost all that it is. We've got skeletal muscle located superiorly, because remember, this is a continuation of the mouth and the tongue. And then in the middle of the esophagus, we're going to start to see a transition from skeletal muscle into smooth muscle. And about the bottom third of the esophagus, we're going to be largely, actually, we're going to be completely smooth muscle at that point, since we're not going to have any control over what's happening there. Now remember, the esophagus is outside of the peritoneum. There's no it's not part of the peritoneal cavity. So because of that, it's not covered with a serosa, but it's covered with a fibrous adventitia. When we look at this picture, what we're looking at is a collapsed piece of the esophagus, and we're going to see here pretty much everything, the same stuff that we're going to see throughout a large part of the alimentary canal. So you're going to have a lumen. That's what this white space is. So this is the open area, and the esophagus will be largely collapsed. And then we're going to have this mucosa lining. So here we've got our stratified squamous epithelium. Once we leave the esophagus, we're going to be in simple columnar. And then we're going to have the submucosa in this region, just underneath it. And it's a rather robust structure. So, because remember, this is where we're going to have areolar connective tissue that is embedded with blood supply and lymphoid tissue, as well as mucus producing glands. And then we're going to have a couple of muscle layers. So we're going to have a circular muscle layer here, and then our longitudinal muscle layer here. And what's hardest to see is that outside here we've got an adventitia. That's our outer layer. For the rest of the alimentary canal that is within the peritoneal cavity, it's going to be the serosa, but here we've got adventitia. I think I would know that. That's probably a pretty important detail. All right, so now we're in the stomach. And the stomach is largely a temporary storage tank for the food that we've eaten, the bolus that we've made and swallowed. And we're going to dump in some chemicals to start digestion, largely of proteins. Proteins take a lot of effort to break down. I mean, fats do too, but proteins are such big molecules that they need a lot of they need a lot of help. Now, once our bolus has made it into the stomach and it starts to mix up with the stomach secretions, we're going to stop calling it a bolus, and we're going to call it chyme. So a bolus is still fairly firm. It's food that's been mixed with saliva, and it's certainly not something you'd want to eat anymore, but it's not as liquidy as what we're aiming for once we get it into the small intestine. So this is a point where we're going to be starting to add a lot of liquid to that bolus, and we're going to turn it into something that's more fluidy and paste-like. Now the stomach can hold about 50 mils of food, but it could hold up to 4 liters of food. That's a possibility. Now when the stomach is collapsed, the stomach mucosa forms these folds that accordion up, and we call those rugae. And there's a couple of places that we're going to see this moving forward. There's a couple of other units where we'll actually revisit the concept of rugae, where we have an organ that, when it's not in use, is kind of accordioned up, and we'll see these folds in its inner lining. The stomach is a rather large organ, and it has different regions to it, and the different regions are, as you can expect, doing different things. So we have the cardiac part, also known as the cardia, and this is what surrounds the cardiac orifice, and this part is actually rather close to the heart, which is why it is called the cardial part, or the cardia, or the cardial region. Now we do have a large rounded part of the stomach that kind of sticks up on the left side. That dome-shaped region is a fundus, and this is what is kind of snugged up underneath the diaphragm on the left-hand side. It tapers down into the mid portion of the stomach, which is known as the body, and then it starts to taper down to a narrow funnel-shaped region known as the pylorus or the pyloric region. It's larger towards the body, and then it will taper down until it terminates in a pyloric valve. So there's a sphincter at the end of the stomach in the pyloric region that helps hold food in until the body's ready to release it into the small intestines. All right. So the pyloric region can be teased apart. You've got a wider, more superior part that is close to the body of the stomach, and then it tapers down into the antrum, which will lead to a very narrow canal, which will ultimately terminate into the pylorus at that pyloric sphincter or pyloric valve. So let's take a look at what we've got here. So here's our esophagus, and it's going to meet with the stomach in the cardial region or the cardia. Here's our large rounded part known as the fundus, and it's going to taper down into this region, which is known as the body. And then as it starts to narrow, we're now into the pyloric region. So the first part of it is the pyloric antrum. Antrum means like the first part. And then it'll taper down into this more narrow region, the canal, and then ultimately it'll terminate here at the pyloric sphincter in the region known as the pylorus. And these are all the different parts of the stomach. So we'd have the sphincter here, the lower esophageal sphincter, the cardiac sphincter, the gastroesophageal sphincter, whatever you want to call it. It would be located roughly right, I guess maybe right in this region here. Now, I know we're going to get to this, but while we're looking at this picture, I want to point this out. Where the rest of the alimentary canal has 2 layers of muscle, a circular layer and a longitudinal layer, the stomach is going to have 3. So we have our outer longitudinal layer, just like we have with the rest of the canal, and then we have our inner circular layer, just like we have with the rest of the canal. But the stomach has this one additional oblique layer, which helps the stomach not only mash and move the food along, but it allows a ringing motion so that the stomach can actually really churn the food up and mix it with the stomach enzymes and the hydrochloric acid. Now, the visceral peritoneum creates this structure known as the greater omentum. And the greater omentum is this tissue that drapes inferiorly from the greater curvature of the stomach, the bottom curve of the stomach, over the intestine, the spleen, and the transverse colon. And its job is to basically provide protection to those structures. And it's interesting because it contains fatty deposits as well as lymph nodes, and it's just a weird structure that you see. And when you do a dissection and you peel back the abdominal muscles and you look at that for the first time, it looks exactly like an apron draping over the intestines. That's the greater omentum. Now there is a lesser omentum that also comes off of the stomach, but it comes off the lesser curvature, the upper curvature, and it kind of drapes in back. But both of these are part of the visceral peritoneum, like an extension off the visceral peritoneum, and its job is to create a covering, additional protective layer for the intestines. All right, the small intestine, this is the major organ of digestion and absorption. Now, we haven't really talked about digestion and absorption and exactly what those mean. Digestion means to break down food, and absorption means to absorb the nutrients. So there are parts of the alimentary canal where digestion occurs. There are parts where digestion and absorption occurs, and there are parts where just absorption occurs. So that we're going to get into that a little bit later on, but I did want to point that out, that there is a difference between digestion, which is the breakdown of food into its basic blocks that we would consider nutrition, and then absorbing it is the act of moving it into the bloodstream so that it can get to the tissues. Now it's 7 to 13 meter, excuse me, 7 to 13 feet long from the pyloric sphincter all the way down to the end at the iliac ileocecal valve where it attaches to the cecum, which is the first part of the large intestine. And I know people are going to say, hey, man, I thought it was like super long. Well, when you have living tissue, there's a little bit of tone to it, and the tissue will be a little bit contracted. So a living live small intestine is only about 13 feet long, but in the deceased state, that tone comes out of the intestines and the tissue elongates, and so that's where you get that extra footage. It's not very big in diameter. It's only about an inch to an inch and a half in diameter, although it can stretch, but we don't want it to stretch too much because that will elicit a pain response. There are 3 subdivisions to the small intestine. The first one is called the duodenum, also pronounced duodenum, just however you want to say it. And this is mostly retroperitoneal. So this is one of the parts of the intestine that is not entirely within the peritoneal cavity, which means that part of it will be covered with a serosa outer covering and the other part of it will be covered with an adventitia. This is only about 10 inches long, but it's a very important 10 inches. It is the first part of the small intestine of the stomach, and it has attachments to the pancreas as well as the liver and the gallbladder. So it's going to be receiving these digestive juices that are going to start to work on the food as it moves into the rest of the small intestine. Now the next part of the small intestine is known as the jejunum, and it's about 3 feet long. And then the last little bit is the longest, and it's known as the ileum. This comes in at about 6 feet long. And I know that doesn't all kind of add up to some numbers that I gave you, but these are just kind of rough averages. So you get the idea that the duodenum is the shortest one, the jejunum is a little bit longer, and then the ileum is going to be the longest part of this small intestine of ours. The ileum is going to be the part that is attached to the large intestine, and there is a sphincter there that will control the movement of the food residue from the ileum into the cecum, and that is known as the ileocecal valve. The large intestine is an interesting structure because it has 3 unique features that we don't see anywhere else in the body. I'm not even sure we see anything like them anywhere else in the body. And one of those is the tinea coli muscles. So these muscles are going to be on the outside of the large intestine. They run in these bands on the outside, and when it contracts, it helps move food or residue along in the large intestine. Now it always stays a little bit toned, which is why it creates these pockets or these little pouches in the large intestine, and those little pouches are called haustra. If we're talking about one, it's a haustrum. But the fact that we see that those little undulations, those little pouches in the large intestine is because of the presence of the tinea coli muscle bands which run around the outside of it and keep a little tone and keep that thing kind of accordioned up a little bit. The other thing that we see are these little fat-filled pouches that are part of the visceral peritoneum that are called epiploic appendages, almost like maybe a modification of the omentum, and I'm just speculating when I say that, but we just don't see that anywhere else except here in the large intestine, those 3 things right there. Now, do we expect that it's going to have a mucosa, a submucosa, a little bit of muscle in there, and an outer covering, whether it is serosa or a adventitia? Yeah, we're going to expect to see all 4 of those things in the large intestine, as well as these 3 special things. So the very first part of the large intestine is known as the cecum. So our residue, our food that we basically have exhausted as far as what we can extract from it, is going to leave the last part of the small intestine known as the ileum, and then traverse the ileocecal valve, and then it lands into the cecum. Cecum's not a large part of the large intestine, but it is that very first part, so we have to acknowledge it. Attached to the cecum is the appendix. And this is lymphoid tissue that we learned about in the previous unit. It's part of that mucus-associated lymphoid tissue immune system. It stores bacteria, which is not together all bad because there are points in our life when maybe there's been an imbalance in our microbiome of the gut, and we need to re-inoculate it with healthy bacteria, and the appendix can do that because it tends to be a storage site for our healthy bacteria. It has a little bit of a natural twist, an undulation to its shape, which makes it susceptible to blockages, and that leads to things called appendicitis, which is usually a surgical intervention in order to get that thing out of there, because you don't want it to explode and spread infection all throughout your peritoneal cavity. Now, the colon is going to have several regions, which are mostly retroperitoneal, except for the transverse colon and the last little bit, the sigmoid colon. So just know that there are portions of the colon that end up being outside of the peritoneal cavity. So the first part of the colon as it comes off of the cecum is the ascending colon. And this is going to travel up the right side of the abdominal cavity up towards the basically where the liver is. And then it's going to make a hard right and become the transverse colon. Now, where it makes that hard right, we would call that the right colic flexure or the hepatic flexure, and it's named because of its approximation to the liver. Or we could just call it the colic flexure because it is it's on the right side of the, and it's the colon. We could call it either one of those. Now, the transverse colon is going to travel across the abdominal cavity rather high, like up towards the liver and the stomach region up in there. And then it's going to make another right-hand turn near the spleen in order to become the descending colon. And at that right-hand turn, we can either call this the left colic flexure or the splenic flexure, calling it splenic because it's named due to its approximation to the spleen. Now, the descending colon is going to be moving down the left side of the abdominal cavity, and then eventually it's going to migrate towards midline through the S-shaped sigmoid colon, which we're now back into the peritoneal cavity, because remember, large portions of the ascending and descending colon are outside of the cavity, retroperitoneal. So now we're back inside the peritoneal cavity, going through that S-shaped sigmoid colon, and then we get into the rectum, which is kind of like a storage tank for our feces. And we actually have these three rectal valves. Now, up until this point, we've interchangeably used the word valve and sphincter, but these are not really sphincters. These are more like shelf-like structures that prevent stool moving before we want it to, while allowing gas to pass. So handy little things, let's just say that, those rectal valves. And then the last little part of the large intestine is known as the anal canal, and this is the part of the alimentary canal that's going to open to the body. The mouth opened at one end and the anus is going to open up at the other end. And here we're going to have two real sphincters, not valves, but sphincters. We're going to have an internal anal sphincter and an external one. The internal is made up of smooth muscle that we don't have any control over, and the external is made up of skeletal muscle, which we do. So we do have a little bit of control about when we want to move our bowels, but sometimes Mother Nature has other plans for us. I think we're all aware of that. And when you got to go, you got to go. And your skeletal muscle allows you to hold it until hopefully you're at a good spot where you can go. All right, let's talk about the different mechanisms of the different things that we do here with our alimentary canal. So ingestion. Ingestion is when we put food into the digestive tract, and it starts out at the mouth where we put the food in and we chew it and we mix it with saliva to form that bolus. All right, then the bolus gets swallowed, it enters into the esophagus, and this is the last voluntary act that our food will experience from us until we get to the very end of the line and we do defecation and relax that external anal sphincter. Now, the rhythmic alternating contractions of our muscular layer of our alimentary canal is going to be what propels the bolus to move through the digestive tract, starting off in the esophagus. And this rhythmic contraction, these wave-like contractions that are going to move the food along, that's called peristalsis. And we're going to see that happening starting in the esophagus and all the way through the intestinal tract until the very end of the line. Mastication is the act of chewing, and the act of chewing is what's known as mechanical digestion. So when we take the food and we squish it around and we mash it up, that's mechanical. If we're dumping in enzymes, that's chemical. So anatomists like to make the distinction between mechanical digestion and chemical digestion, and where are we doing each of those. And when we do mastication, the act of chewing, that is just a physical act of breaking the food up into smaller particles. This is going to involve the teeth. It's also going to involve the tongue, because remember the tongue has a little bit of tread on it by way of those lingual papilla, some of which contain our taste buds, and it's going to allow us to move the food around in order to break down the large parts and get them into small parts. So the tongue is also going to move the food around and mix it with saliva, so that the saliva can begin doing chemical digestion. But the act of just mashing it up and down, doing the chewing thing, that is mechanical digestion, and that's mastication. Now, deglutition is just a fancy name for swallowing. But swallowing is a rather complex action because it involves coordination between voluntary motion and reflexive involuntary motion. So we have a voluntary phase. So after we've chewed our food and moved it around and we created that bolus, our tongue is going to move the bolus posteriorly in the oral cavity. And then we move into what's known as the pharyngeal phase. And in the pharyngeal phase, this is where we cross over from a voluntary act to an involuntary act, a reflex, more or less. And this is where the medulla oblongata is going to get stimulated. So the presence of the bolus in the back part of the mouth, back there getting close to that oral pharynx, is going to stimulate the medulla oblongata, and the medulla oblongata is going to trigger the soft palate to be moved upwards to basically close off the nasal cavity. It's going to cause us to pause our breathing so that we can get that coordinated effect in place, so we don't move the food in the wrong place, and we can direct it where we want to go in the next phase, which is known as the esophageal phase. So the bolus has stimulated the medulla, caused the soft palate to lift, breathing to pause. Now we're going to trigger the peristalsis in the esophagus, and we get the distension happening there in the esophagus. And there's actually an upper esophageal sphincter. We never mention this in anatomy, but there is one. And so that will have to open up, and then the bolus moves past that, it closes, and then we start that rhythmic contracting as the bolus makes its way towards the stomach. And when the bolus reaches that cardiac sphincter, that lower esophageal sphincter, that gastroesophageal sphincter, whatever you want to call it, the distension in that part of the esophagus is what's going to trigger the sphincter between the esophagus and the stomach to open up and allow the food in. So as you can see, we just think of swallowing as like one and done, but there's actually 3 different phases, and it involves our coordinated actions as well as coordinated voluntary actions, as well as coordination with our involuntary actions. Now, absorption occurs primarily in the small intestines. So absorption is when we take the foodstuffs that we've broken down into their basic components and we're moving it into the bloodstream. That's absorption. Now, there is some absorption that can take place in the mouth You know, we've all probably heard that you can dissolve an aspirin under your tongue and, do that sort of thing. And there are a few things that will be absorbed through the stomach lining, but mostly things like alcohol and aspirin, not necessarily foodstuffs. But largely all of that absorption that we think about when we think about eating in order to be nourished happens in the small intestine. And there, because we have so many things that are in our food as far as carbohydrates, there's some different types of sugars that are in there, and fats and proteins, amino acids, and then the nucleic acids. We have a number of different mechanisms in happening in the intestinal tract that are going to move those food the nutrients out of the intestinal lumen and into the blood. So one of them is active transport, where we actually require the use of ATP to move things from one area to the other. Now, the rule of thumb when we utilize ATP is that we're typically moving things from an area of low concentration into an area of high concentration. That always takes a little bit of work. It's like trying to throw one thing in a closet that's already full of things. So, you usually have to do a little work to make that happen. And the same thing is true in the body when we're trying to move substances from an area of low concentration into an area of high concentration. Another mechanism is passive diffusion. And this is where we're going to just rely upon the concentration gradient, where we'll move things from an area of high concentration to an area of low concentration. Then we have facilitated diffusion, where we might be utilizing a carrier protein, such as a channel, to move things through. Again, we're following a concentration gradient with that, moving it from high to low, not requiring the use of any sort of energy to make that thing happen. Then we have this mechanism known as co-transport or secondary active transport. And in this system, what's happening is that the body is intending to move a molecule from an area of high to low concentration, and that creates a flow, if you will. It creates some sort of a gradient that will bring other molecules along with it. So so there's a number of things that are happening here as we're moving substances across. So it's not uncommon, for example, for the body to move sodium from one area to another area, and then chloride will follow, or water will follow, or even something like glucose will follow. Another charged particle will follow it, because many of the particles that we're moving around will have charge to them, and not only will they be following a concentration gradient, but they will be establishing a chemical charge gradient as well that can cause other molecules to move along the same pathway. And then there's endocytosis, where a cell lining the intestinal tract will engulf a substance and then take that vesicle and then move it to another part of the cell and then release it into an area outside of the cell. So that's endocytosis. So it does initially do an endocytosis and then an exocytosis, but it's a combination of getting it out of the lumen into the blood supply, and the thing that we're worried about is getting it out of the lumen, which would be the endocytosis act. And whenever we do a cytosis like that, an endo or an exocytosis, that always requires the use of energy. So movement out of the intestines is what we would call absorption. Carbohydrates largely move through a co-transport mechanism following some ions, and that was one of the examples that I gave, that we can move sodium around, and then we're just going to have other molecules like glucose tagging along. This is kind of that's going to require ATP, because whenever we move sodium around, we typically have to move it by using ATP. We might also be using facilitated diffusion to move the carbohydrate around as well. Protein also uses a co-transport mechanism. It'll latch onto the movement of ions in that gradient that gets created as ions get pumped from one area to another. Lipid movement, it can happen through simple diffusion, and depending upon the fats, they might be tucked inside of a structure known as a chylomicron. And the chylomicrons are going to be what gets taken up by the lacteals, those special lymphatics that we see only in the small intestines that are designed, that are capable of picking up these larger structures known as chylomicrons that are filled with lipids. Nucleic acids typically require some sort of an active transport, so you have to use a little energy to move a nucleic acid from one area to another area. Now, we mentioned segmentation in the first unit. We said that this was one of the motions that gets created by that muscularis externa layer in our alimentary canal. And what segmentation is uh, a movement that will allow the contents in an area of the small intestine to be squished and mixed with digestive enzymes. So it's a form of mechanical digestion, which is different than just, merely peristalsis, which is just intended to move the residue from this area to that area. Segmentation can create motion as well, but that its intention is to create a mixing of the food or the chyme that's in the small intestine. Right. So this is the most common motion that we're going to see in the small intestines. It gets initiated by pacemaker cells in the intestinal wall. As it mixes the food, it knows what it's doing, and it's going to gently propel that mixture towards the ileocecal valve. So it's not going to allow it to come back up towards the pylorus and make its way back into the stomach. It knows which way is which. The intensity is going to be altered by long and short reflexes and various hormones. So that's just telling us that we've got neurological input as well as hormonal regulation that is guiding the motion of segmentation in the small intestines. So we might remember that we talked about parasympathetic and sympathetic input in the digestive tract, and that parasympathetic input is going to stimulate the digestive tract, whereas sympathetic input is going to decrease that. So that's just what that last line on this slide is helping you remember, is the effects of sympathetic and parasympathetic innervation. Now, peristalsis is the movement of the food along, and its job is not to do mixing, but just to basically move the residue along. And in between meals, you've got a hormone known as motilin that will be released late in the intestinal phase, and it's going to start these wave-like motions of peristalsis in order to move things out. Because the longer that something stays in the intestinal tract, the longer it has to putrefy, and that's never a good thing. So we've also got possibly the growth of bacteria taking place that's going to lead to that putrefaction. So we just want to get all of that residue out, and that's going to basically happen, every couple of hours. We're going to just do this cleansing action to get stuff out of the intestinal tract and move that towards the ileocecal valve. The complete trip from the beginning of the duodenum to the end of the ileum should take approximately 2 hours, and of course that can vary from person to person depending on what's going on. In this image, I wanted to demonstrate the difference between peristalsis and segmentation. So as we can see here, the arrows are telling us that the intestine or the tube is going to be doing a sequential contraction that is going to just be intended to move that food residue along in the pathway, whereas segmentation is going to take the brown bit and the gray bit and then divide it and then mix it till it becomes this sort of khaki colored bit. And largely these are all going to stay kind of in the same area. I mean, it is possible they're going to be gently moved along in the process, but definitely they'll be moved along with peristalsis. Now, defecation is another movement that we're going to see in our alimentary tract, and this is when we move feces towards the rectum, and then distension at this point is going to initiate the spinal reflex known as defecation. So what happens here is that we have parasympathetic signals that are going to stimulate the contraction of the sigmoid colon and the rectum. And it's going to cause the internal anal sphincter, which you might remember smooth muscle. It's going to cause that to relax. And then our skeletal muscle is the last thing that becomes engaged, which is us saying, oh, I need to go. So we'll go and then relax that, and then we have our movement. So the muscles of the rectum are going to contract to expel the feces. So it's not necessarily the anal sphincter that's going to expel it, because the anal sphincter is just there at the end. It's actually the musculature in the rectum that's going to do that. And we can assist it consciously by bearing down. So that bearing down is called the Valsalva's maneuver. So when you do that, you probably never thought of this, but what you do is you close the glottis, which is that little trap up at the top of the larynx, up at the top of the trachea. You close that and you contract the diaphragm, and you basically create a lot of intra-abdominal pressure. So you take a breath in, you got an air full of lungs that just kind of takes up some real estate, and then you squeeze your abdomen real hard, and you just force. You're putting a lot of force on the colon when you do that. The other thing that happens is that there's a muscle known as the levator ani muscle. That's going to contract, and that's going to cause the anal canal to be lifted superiorly, and that will aid in the feces leaving. So we have relaxation of the sphincters. We've got the sigmoid colon contracting. We've got the levator ani lifting up, and out comes our stool. Hallelujah. Now, we've talked a lot about the mouth already, and we know that the oral cavity is bounded by the cheeks, the tongue, and the palate. This is the site of ingestion. It's also the site of mechanical digestion, the chewing thing. It's also the site of deglutition, the swallowing thing, and something we didn't really mention heavily in the previous section, it's also the site of the initiation of chemical digestion, because our saliva has a couple of enzymes in it that are going to work on two classifications of foodstuffs. It has an enzyme known as lipase, which is going to break down lipids. And it also has an enzyme called amylase, which is going to start the breakdown of carbohydrates. Now, we don't have a significant amount of digestion occurring, but we start it here, and you need to know that. Now, we've already talked a bit about the tongue and that it plays a role in ingestion. It helps us bring food in. It plays a role in mechanical digestion because it allows us to position the food so that it can be chewed. And it also plays a role in chemical digestion because it helps mix the food with the saliva. It plays a role in our sensation of our food, detecting the texture of food, because there are certain textures of food that I absolutely love and some that I can't stand. And I know you have your own preferences. It initiates swallowing, deglutition, and of course we know that it helps us with our vocalization because it helps form our sounds into intelligent, hopefully, words. It's studded with these little pokey-uppy things called papilla, and many of these papilla harbor taste buds, and some of them are just there also for grippage. I don't know if that's a real word, but it's a word that I use, and I think you know what it means. It acts like tread. So we've got taste buds housed there, but it also allows us to grip our food by having it be a little bit rough, having that rough tread on our tongue. We have lingual glands that are going to secrete mucus and serous fluid. So our salivary glands will do that. And that's basically what we're talking about here. The lingual lipase, which is the saliva that's coming from underneath the tongue, is going to contain lipase as well as a serous fluid. And I know we studied we looked at earlier the parotids, the submandibular and the sublingual glands, and we said that these are all salivary glands. They're going to produce a combination of very liquidy saliva with enzymes and a little bit of mucus. And you don't need to know who's producing more mucus than liquid and who's producing more liquid than mucus. You don't need to know that, but you do need to understand that they are different, and that that saliva is a combination of liquid serous fluid, which contains enzymes, and mucus. I would know that. So what is saliva actually doing for us? Well, certainly it helps dissolve our food. That's a big thing that it does, as far as starting to break down through chemical digestion. But it also helps cleanse the mouth, and it helps preserve the integrity of the teeth by doing that. We might think of that as kind of counterintuitive because it does contain enzymes, and you might be thinking, well, you know, where does it stop and and not digest us? But it's not designed to be super strong because Mother Nature knows that we need to preserve our enamel and we need to leave our mucosal membranes largely intact after a meal. So saliva actually helps cleanse the mouth. And I read an interesting article one time that said that if you chew sugar-free gum after a meal, it will actually go a long way to help keep your teeth in better shape because of the extra saliva that gets produced and can help cleanse the mouth of any food residue. So yeah, there you go. Um, it dissolves the food in liquid because you might remember from AMP1 that we have to dissolve odorants and food particles in order to taste them. So to kind of figure out what we're putting in our mouth and whether or not we like it, we have to have a little bit of fluid there. And it's going to moisten the food. It helps create that bolus that we want, not a dry, dusty nugget of, something that we're going to try and shove down the esophagus. We want it to be, kind of moist, so we're not doing a lot of damage while we try to get it down into our stomach. And then, like I said, it also helps us in the digestive process because the saliva is going to start the breakdown of starches or carbohydrates, as well as begin the initial breakdown of our lipids. Now, most saliva is going to be produced by our major salivary glands, which are located outside of the oral cavity. Because remember, the parotid is outside the masseter muscle, and the masseter muscle is actually outside the oral cavity. And the sublingual is under the sublingual, and the submandibular are under the tongue. And the tongue is the boundary of the inferior part of the oral cavity. So that's why they call them the extrinsic salivary glands. Now, these are not the only salivary glands that we have. We have salivary glands scattered throughout the oral cavity. It's just that they're really, really small, and we don't need to go through the act of trying to figure out where they all are and to name them all. So, yeah, they're just kind of scattered throughout. Now, we know that the pharynx is the throat, and that it's a passage for both air and food because it gets shared by respiratory and digestive systems. It's the transition area between our voluntary and involuntary aspects of deglutition or swallowing. And it's in this area that we're going to signal the medulla oblongata to trigger the contractions that are going to propel the food inferiorly towards the stomach. Now, we've already talked about the esophagus quite a bit, so we can just be brief here. We know that it's a muscular tube. It's lined with mucosal tissue that harbor mucus glands, so it's going to continue to add the fluid content to the bolus. The upper third is skeletal muscle. The middle third is largely a combination of skeletal and smooth muscle. We're going to eventually transition to entirely smooth muscle down at the bottom third of the esophagus. It's going to be lined with non-keratinized stratified squamous epithelium. And at this point, this is going to be the last structure where we see this sort of epithelial tissue until we get into the anus. So this is the last hurrah for stratified squamous epithelium for a while. And it's going to perform peristalsis to move the bolus into the stomach. Now you'll notice I didn't say anything about digestion or absorption here because really the esophagus is just a passageway. We don't have either one of those things happening here. So we don't expect the esophagus to do mechanical digestion, chemical digestion, absorption, nothing except just movement. Getting it from point A to point B.